Welcome to Fibroid Awareness Month 2025. One question that we are often asked is, my doctor said I should have a hysterectomy, but I don't want to lose my uterus. Are there any other treatment options for me? Fortunately, you have options to treat your symptoms, and it's important for you to consider all of your options before making the best decision for you. Treatment considerations may be different if you're recently diagnosed, near menopause, or if you wish to become pregnant soon. Each option has benefits and drawbacks. Understanding your medical and surgical management options will help you select the best option for you to achieve your treatment goals. Today, we're discussing a serious question: can I save my uterus? I'm joined by Dr. Pierre Johnson. Dr. Johnson, also known as the Fibroid Slayer, is a minimally invasive gynecologic surgeon. He graduated from Xavier University of Louisiana with a BS in biology, an MD from the University of Illinois College of Medicine, a general surgery internship at Washington Hospital Center, and completed his OBGYN residency training from Southern Illinois University School of Medicine. Through extensive training and vast experience, Dr. Johnson has developed a niche to surgically manage the most difficult gynecologic cases. He professes that no fibroid is too big to manage, and every woman should have the option to preserve her uterus. He has over 13 years of experience with the Vinci robotic surgery method and 9 years with Acessa. Dr. Johnson is a board certified OBGYN specializing in minimally invasive surgery, pelvic floor repair. He's a sexual health expert and also offers vaginal reconstruction. Dr. P, thank you so much for joining us for this important discussion.
Thank you for having me. I appreciate it.
So it's always such a pleasure to speak with you because you have so much knowledge and experience. And so I'll just jump in with the first question.
Sure.
When a patient comes to you for treatment, what are some of the factors that you consider when determining what surgical treatment, if surgery is required, would be best for them?
So when a patient comes to me for any issue, I always one before even analyzing their situation, the very first question is what's the goal? Because the the thought of everything is it needs to start with the goal first in mind, because when most people talk to doctors, it's just kind of coming up with whatever solution they want to, but it always has to be predicated on the goal. And the misconception, especially for women with fibroids, is that fibroids are always the problem. Fibroids cause bleeding. Fibroids cause infertility. Fibroids are ruining life. Fibroids are changing my mood. Fibroids are making me gain weight. There's so many things that are happening in bodies, and the most feared thing and the thing that's most obvious is always blame. So really understanding what the goals are and then also finding out what the true problem is to get a true diagnosis is extremely important as it pertains to getting to the treatment option that makes the most sense for a woman. So that's I have to level set most of the patients that I come in because they've heard so much misinformation that it really becomes a confusing thing. And so that's the biggest thing, is just really trying to figure out what the issues are, but more importantly, what the goal is. And then we can start talking about the treatment options that make sense.
And I'd like to expand on that because you brought up patient emotions, because when you're suffering from heavy menstrual bleeding, as I have, and it maybe has happened for many years or even decades, there are a lot of emotions around um, having to withdraw from social activities, any relationship burdens that may take place as you're dealing with a fibroid diagnosis. And so when a patient comes into your office, when you're attempting to try to help them to get to those goals and to unpack their experience and make a good decision on their care or provide information that you need to kind of guide them in the right direction. Can you just share maybe a couple of things that you say to them to help them kind of navigate that decision making?
Sure. I tell them that what first and foremost, keep an open mind, right? I want them to just listen to, someone that is going to treat them like a person and hear their goals and hear the things that they're really concerned about. So that's, like I said, it's very difficult because there's so much misinformation and so many things that people hear that clouds the judgment and automatically um, brings people in with apprehension, brings people in with, misconception. So it kind of makes the conversation difficult. So one, just really trying to level set those thoughts and emotions. But then two, really start to educate, because there are things that two things can be true at the same time. A woman can have very bad menstrual bleeding and she can have fibroids, right? There are so many things that can cause abnormal bleeding that are not really even associated with fibroids. For instance, one of the major issues is something called anovulation or anovulatory bleeding, right? So the decline of the ovaries happens to every woman, and eventually it starts to change the ovulation pattern, meaning that a woman will not ovulate regularly. And that's how menstrual cycles are regulated, through ovulation. And one of the progressions of things that can happen is that a woman starts to not ovulate regularly, and she starts to have very bad or irregular menstrual cycles. Well, if she also has fibroids in addition to that, someone that does not understand that physiologic aspect can just say, hey, I'll do this to your fibroids, or I'll treat your fibroids, or I'll remove your fibroids, but not understanding the true cause of the problem, not give her the options that really make sense for her. So really breaking down the physiological, uh, you know, things that are happening in a woman's body is how I really try to present the information, which then will allow women to start to make more informed decisions. And when you have any advice that I give to women is to say, listen, when someone talks to you, they should say it in a manner that makes you feel comfortable. Then not only makes you feel comfortable, it also make you understand about what's happening. I'm not a lawyer, so when I go in and I speak to any lawyer, I expect them to talk to me in a manner in which someone knows that I didn't go to law school. And so when I talk to my patients, I talk to them in a manner where I know they didn't go to medical school, or they don't know what's going on in their body. And that's how physicians should speak to their patients. And if you don't feel that way, then you should automatically make an immediate switch or change to your care provider. No, I
Yeah.
didn't. I think I didn't answer everything that you said. Sometimes I go off on a tangent, but
No,
that's
I
what it
mean,
is.
I appreciate that feedback. And a lot of times during some of our research team meetings, I bring up the point that in every industry, I think sometimes when you're familiar with the subject matter, you assume that people you're talking with are also familiar with the subject matter.
All
And
right.
so it's a good reminder for everyone, the providers watching this program, as well as the patients, that not everyone is familiar. And there needs to be a communication strategy that takes that into account. So I appreciate all of that feedback. Thank you so much for that.
Words.
You're well versed in removing large fibroids successfully. That's kind of an understatement. You're just phenomenal. I've seen a lot of your surgeries, and I'm just blown away with the large fibroids you're able to remove. Why? And we've had this conversation before, but I wanted to bring it up again because it's still an issue. Why are skilled fibroid surgeons, in your opinion, still so rare?
Scale fibroid surgeons are rare because, one, surgeons, most surgeons will gravitate to things that are easy. right? That when things get very complex and difficult, it's not something that it's a road less travel. It's easier to not deal with those situations. So when you do that and you avoid these tough cases and difficult cases, you don't gain experience. You don't gain the knowledge that you need to, because with difficulty, with tribulations comes growth and it comes learning. And so if you avoid those cases, you just will never get to that point. The other thing is that there's not enough emphasis on the importance of this work, right? Because hysterectomy, a lot of times it's easier. It's much easier. It's easier on the surgeon. It's easier on the OR staff. It's easier on the hospital. It's just easier to do, as opposed to a more complex surgery of removing all these fibroids, preserving the uterus. So we always travel down the path of least resistance. So surgeons don't want to really take on the cases and do more work when you don't necessarily have to. So therefore the option of myomectomies and preserving the uterus is just not there, because it's much more complex. It takes more time. And then understanding the importance and the value of it, and how significant, the decision to, either infertility or to remove the uterus is for some women, and not being sensitive or empathetic to that is also another reason why the option of myomectomy is not done. And then that's another reason why the skill level for performing these surgeries is just not there. We're sorry, let me put if we could pause right there. Let me put my phone on do not disturb so we don't have that problem. Uh, sorry about that. Sorry about that. We okay?
Yeah, you're fine.
Okay. So um yeah, so it's a multitude of different things that play a factor into why the skill level isn't there. The things that I do now, I wasn't really taught in residency. I never saw a 20-pound fibroid in residency, and it's for me to practice and learn. Or I never saw these cases like this. I saw some complex cases, but I never saw cases that I'm performing now at the level and the complexity that they are. I didn't, but the desire in me to be able to learn and to tackle these cases was always there. I'm just a person that will don't accept defeat. I don't accept no. I don't always take a challenge. I always want to help people regardless of whatever the situation is, no matter how complex it is. That's just a desire in me as a person, outside of being a doctor. That's just who I am as a person. And so you have to have an element of that too. And a lot of times people don't have that for people that don't look like them, or people they don't have affinity for, especially. So that's another part of the problem as well too. It's just an overall lack of empathy, lack of skill, and it comes from just not wanting to develop that type of level of skill or meticulousness, just because there's just no true reward in it. There's nothing there to just say, hey, I want to do this for this group of people. That's where the problem lies.
Absolutely. And a lot of what you touched on is really just having the confidence to advocate for yourself, and changing the historical uh, tendency in some cases to just go along with any provider and do whatever any provider says, rather than finding a provider who's empathetic like you are, and skilled, and asking questions, and emphasizing your particular singular goals, and having those goals addressed. So I hope that this conversation will help our listeners and providers to have better facilitate better conversations, and ultimately have better outcomes. I think a lot about pre-surgery and post-surgery methods and strategies, and it always brings me back to when I had my open myomectomy. I knew at that time that my feedback was helping the surgical team to address some questions that I don't think that they may have had gotten before from patients,
Mhm.
or to be prepared to better explain potential symptoms from pre-surgery medications, or I felt like some feedback, there needed to be some feedback to prepare you for what you'd expect post-surgery. Um,
Mhm.
so in your opinion, are there pre-surgery and post-surgery methods that promote better outcomes?
Yes, absolutely. That's a great question. I've had I've had multiple cases in which physicians have went in and have been clearly over their heads and have performed surgeries that have really harmed women that I would have to come back and to correct or to now do what they needed to be done. And from a pre-surgical standpoint, is yes, getting a full history on a patient, understanding what their surgical history is and what the complexity of their case, and being honest about if that's something that you can handle is really, really important. And that's a thing of importance for not only the physician, but for the patient to really understand, like, is this person really confident about what they're doing to me? And you can ask very specific questions about that to a provider to gauge their level of comfort with your particular case. One thing is just to ask them, have you encountered cases like this? Or in your how many cases of these have you had to convert to a different thing that you've had to convert to hysterectomies? Or, just kind of really feeling this doctor out and getting their level of expertise and their comfort level to those cases. I literally have, 2 weeks ago, I had this woman that had myomectomy surgery uh, in April, and the doctor clearly was over her heads in what they tried to do. Open her up, pulled out a couple fibroids, and she still has a 32-week size uterus riddled with extremely large fibroids. And this woman has, young woman, married, really wants to have children with her husband, and had this doctor just go in and do this surgery, which was her second myomectomy, and remove fiber. She was not absolutely no idea what she was doing to remove these extremely large fibroids, was extremely uncomfortable, but opened her anyway. Not only opened her, but there was bleeding in the case, had to go back in and open her again after that. So now she has three laparotomies, vertical incision, mind you, laparotomies, uh, and still has a major fibroid problem that I have to deal with. So, yes, there are pre-op testing that you can do as far as ultrasound MRIs, but they're not as important as understanding the level of expertise, the level of empathy, and the level of just sheer experience that your surgeon has. And that transcends any laboratory test that you can get. It starts right in the clinic. It starts right in your consultation with your rapport and your dialect with back and forth with your surgeon to get that level of comfort and understand how this person is going to really address your case and how they're going to be able to solve your problem, and getting that comfort level. That's the biggest thing that I tell people is, like, you have to really take your time. This person is literally going to have your life in their hands for 3, 4, or 5 hours, however many hours it's going to take. They're going to have your life in their hands, and you must be 100% comfortable in who that person is. And that starts with the patient, not the doctor.
That uh, there's a lot to unpack there. We actually just had a team meeting talking about scar tissue.
Hmm.
And we know of a few instances where scar tissue has become an issue, and that's something that patients understandably would not, know to plan for or ask about. And when you're looking at multiple surgeries, or in the instance that you just described, having to correct a surgery, which I have been through, there is nothing. It's just very, very, very upsetting to come out
Yes.
of the surgery after you've been cut and realize that the goal for the surgery that you intended was not accomplished. And so then you have to do all these things over again. Fly in, family members to help you with the surgery, prep, take time off from work, heal. You're on I was on medication to prep me for the surgery. Then I was on the drugs for during the procedure, and just coming down off of all of that. It definitely is a lot. And I really I hope that the providers who tune into this broadcast will hopefully share this information that you shared, and hopefully patients will fare better as a result of having these conversations. So I really,
So,
really appreciate you saying that. I also too thought about sometimes we refer patients, and sometimes patients push back, which they're totally allowed to do because they have specific preferences. But when we make a recommendation, it's because we'd like them to have an outcome from a skilled provider like yourself. And oftentimes we get another communication when that patient may have selected someone who was not experienced enough to handle their case, where they have complications. We're communicating with a couple of community members now who are in that exact position. So I just implore everyone to please avail yourself of the information that providers like Dr. Johnson are providing, and take it into account. Take notes with you, take a friend with you if you think you might feel overwhelmed, to make sure that you're asking all the questions, that you are getting your answers to those questions, and that you, as Dr. P indicated, feel totally comfortable in the hands of that surgeon or that provider. It couldn't be more important.
it's
Um,
like I tell them all, this is not a popularity contest.
mm,
This is not, um, hey, can I sit down and have a drink with this person? Or can I go into this person? Go in and, you know, just have, a friendship or conversation with this person. Some of the nicest doctors that I know, I would not trust them to operate on anybody. But they're nice, very nice people, extremely nice people. I,
mm,
I, I love them, but I would not trust them with my life in their hands, or anybody that I love's life's in their hand. And that doesn't mean that they're not good people.
mm,
And so you have to understand that the main objective and the most important thing is your life and the success of whatever it is you're trying to accomplish as it pertains to your life, so that you can do what you want to do very healthy. Right. And so that is your framework that you have to go into these conversations with. You know, it's it's a very delicate thing, but people have to understand that. Like for instance, when when my mother had surgery a few years ago, and in my mind, yeah, I know the type of physician that I want to operate on my mom, but the ultimate physician that I chose, or the surgeon that I chose, didn't look the part, wasn't, different cultural, different culture, different um, you know, thought process. He's a male. It was a lot of things, a lot of check boxes that, wasn't how I went into it with. But at the end of the day, I was 1000% comfortable with his knowledge, his expertise, and I knew that whatever happened in there, he was going to treat my mom like it was somebody in his family. And so anything else didn't matter to me because that was the most important thing. And that's what I tell women all the time. And, I get backlash from it and everything. Like, I don't care who it is. Like, for me personally, it's man, woman, transgender, whoever it is that is going to give the absolute best outcome to whatever it is you're trying to do, that's the person you have to trust because for those hours you are the most vulnerable that you will ever be in your life. You can't fend for yourself, you can't speak for yourself. There's absolutely nothing that you can do. You are dead to the world. There's a breathing tube in your throat that is pretty much keeping you alive. You don't know anything that's happening, and so the person that is standing over you has 1000% control, right? I never say anybody's like God, but for that 3 or 4 hours, they are like God. If they do something that's a millimeter off, a centimeter off, they do this or what have you, and they say, hey, well, I don't really need to do that, and are lazy at a particular point, right? This can change your life forever in just that quick. Right, somebody loses focus or just doesn't have the skill level or gets into a situation where they really haven't been in before and kind of guesses the wrong way and cuts this and puts a suture here, what have you. Your life has changed just like that. And so for that, you have to look at that person that's sitting across from you and put it in the lens of those types of situations and to see how much you trust them. And it has nothing to do with how they look, has nothing to do with their gender, has nothing to do with their background, it has nothing to do with any of that. It's in those instances, in those situations, will that person do the right thing and get you out safely and do the things that you need to do? Those are the questions that you need to ask. And those are the important things that you need to take with you as you go into a consultation to talk to anybody.
I wholeheartedly agree. And like you, we've had requests for certain ethnicities and genders, which I understand, but I think that your advice should override all of that
Mhm.
because you do ultimately want to have the person who is most skilled um, taking taking care of you. So
Absolutely.
thank you for that.
Yep.
Last question. Post surgery, how should women monitor their health? I know there's a lot of conversation about the recurrence of fibroids, and just wondering if you have any feedback on that.
Sir, listen to your body, right? Listen to your body. Post surgery, I never recommend getting now ultrasounds every 6 months or MRIs every year. It doesn't make much sense. Your body tells you when there's something that's wrong. You have to be very in tune with your body. If now you start to have, increased bleeding, or now you start to have, consistent pain with your cycles, or now you start to have pain with sex or more frequent urination or whatever. Let's start listening to the signs of your body. That's the most important thing. The truth of this, I tell people this all the time, and I hear it every day, right? Fibroids are going to come back. Well, fibroids come back. My philosophy on it is different, right? And I've done enough, thousands of cases, and I do more fibroid surgeries than anybody that you can think of, right? In this country and in this world. What I have come up with is that fibroids, as long as you have a uterus in your body, you have a potential for problems. I tell that to every single woman. So with that, you have a ground in which fibroids can return or they can grow back. However, if you have had a fibroid surgery, the chances of those fibroids coming back and becoming a problem for you nullified if your surgeon removes every single fibroid out and restores your uterus. To date, I've been doing surgeries like as intense as I've been doing them for maybe about the past 7 years or so. To date, I have zero repeat myomectomy cases because of that philosophy of removing every single fibroid. 40% of my patients that I operate on have already had fibroid surgeries from other providers, and that coincides with the average or with the average of what repeat fibroids or recurrent fibroids are. It's about 30 to 40% of the time, the cases when a woman has a myomectomy, she'll need another myomectomy or hysterectomy in the future. And I will contend that that number is predicated on the fact that the thought of removing all of the fibroids is not there, is non-existent, because people want to do what they feel, just what's comfortable. The fibroids that they see, the fibroids that they think are problematic. And to that point, fibroids will grow. If you leave them, I don't care if they're pea size, if they are millimeter size or what have you. If you leave them in there, they have a potential for growth. And so if you remove them all, you just don't have enough reproductive time left in your life to where now it can produce from nothing and then now grow into something that's large enough to become a problem. I never tell any woman that, oh, you won't get fibroids again, but I will tell them that it's extremely unlikely after surgery with me that you will now have fibroids that will grow into something that we have to address again. And to the bigger point of the initial question of how do you manage this or how do you look at this after? This is the reason why I don't say get serial ultrasounds or MRIs after fibroid surgery, or at least with me, because if you have a 2 or 3 centimeter fibroid after fibroid surgery and is there, who cares, right? No one cares. It's if you have a fibroid now that is causing you to have bleeding, or it's large enough to make your belly start to protrude. That's what we care about. So, and your body will tell you that before any ultrasound or MRI would be. I could care less if you get an ultrasound and it says, hey, you got a 2 centimeter fibroid. I care more about you saying, hey, I'm bleeding excessively, and these are the things that are happening. Can we figure out what's going on? So that's what I would say. Listen to your body, be in tune with your body, have extensive conversations with your doctor about the things that are going on with your body. Go to, you should be getting annual exams every single year, right? Pap smears are not annual exams. They're part of an annual exam, and you need to be in front of someone talking about your health and your issues every single year. And especially after fibroid surgery, you should be doing this as well. And if you are going into fibroid surgery, they have a very, very strategic conversation with his doctor about what is your approach to removing every fibroid I have out but when you're done, and then hear that and then make your decision after that. But these are the steps that you need to take. And then post-operatively, that's how you should approach your body and everything after fibroid surgery.
Okay, that's fascinating. The statistics are really incredible. I'm intrigued. What would be your advice to providers watching this who have a case with small fibroids or a fibroid near the fallopian tubes where a patient has a desire to have children?
Sure. So my advice is this, is that the conversation always has to be about the goal. If your goal is to have children at the end of the day, that goal has to be looked at from all facets and all angles, right? Just because you want to have a child naturally, right? And that's your desire. That's a desire. The goal at the end of the day is to have a child. And if you want to have a child in your uterus, right, then there are multitudes of different ways that can happen. But just the tunnel vision thought that it has to happen, I have to have sex and be able to have it in my fallopian through and have great fallopian tubes and have it with my husband and nothing else really matters. I don't never want to go into IVF or whatever. It's really tunnel vision, right? Because no one can promise you the pathway, right? And the pathway of sperm meeting the egg and fertilizing, coming back and implanting. There are women without any fibroids whatsoever that have hydrosalpinx and have issues with their fallopian tubes in which the pathway is a problem. So the pathway could be a problem for you. I still contend that no fibroid should be left behind, because it's also another aspect of fibroid surgery, of recurrence and dealing with this surgery again. So what is it if you leave a fibroid or close to a fallopian tube, right? And even say this woman does get pregnant, hypothetically, but now she has to come back for fibroid surgery after that in another 2 or 3 years, right? You have to look at the overall picture of we need to accomplish multiple goals. One, we need to accomplish the goal of getting to be to motherhood. The other is we need to accomplish the goal of not having to do repeat unnecessary surgeries after the initial fibroid surgery. So to every provider, I say that small fibroids or a large fibroid started from somewhere. I don't care how big the fibroid is, whether it's 10 centimeters, 20 centimeters, 30 centimeters, however big this fibroid is, it started off from the size of a pea and it grew. The thing that we don't know right now is why in the world some women will have 1 centimeter fibroids and that 1 centimeter fibroid is 1 centimeter for 20, 30 years. And why some women will have a 1 centimeter fibroid on an ultrasound and then 2 years later have a 12, 15, 20 centimeter fibroid. What's the difference between those women and why that happens? We do not know. So, to that point, because we don't know, I am never a proponent of leaving these small fibroids behind just because they may not be causing a problem right now. They may not be, but the threat of them growing into these large fibroids, you can't assure that person that that's not going to happen. So leaving them is already just saying, like, hey, if you do that, you don't. It may grow, it may not. But if consciously know that they're there and I'm leaving them there, I'm leaving the window of this woman having a problem with these fibroids in the future. And you should not be comfortable with that. Because anything else, if it was a cancer, if it was something that was going to kill her, like you want to get that out. Like you would want to do that. Like when we go in for surgery, we're completeness. If it's not going to do any harm to her, we want to get it and complete it. So this is something that is going to do harm. It could potentially do harm. So addressing it makes sense. And if you're not skilled enough to do that, if it's close to the endometrium or if it's in the endometrium or if it's close to a fallopian tube, if it's not, and you don't feel comfortable with that, then you should now um, recommend that this patient go to a provider that is comfortable with it and feel safe with that and safe to say that.
No, that's really helpful and comprehensive. So last follow-up question. Can you speak a little bit more about what screening you recommend? Because I don't want patients to get confused about listening to their bodies and um, potentially, I don't want them to miss any necessary screening that they
Sure,
need
absolutely.
for all health.
So for screening for just overall health or screening for fibroids or screening for like what specifically just for
Gynecologic screening, like
absolutely.
annual gynecologic screening that is necessary.
Absolutely. So for gynecologic screening, first and foremost, pap smears are important, right? So the old guard was that pap smears should be performed every single year. They should be performed whenever a young girl or woman starts to become sexually active. That's the old guard. That's not true any longer. There are strict guidelines to how we should be maneuvering, right? So pap smears start at the age of 21. And from the ages of 21 years old to 30 years old, they should be performed every 3 years. And if there are abnormalities in that, then there's a whole algorithm as far as how you address that. So for instance, if a 22-year-old woman had a abnormal pap smear, there is a thing that will show if she should have a pap smear before that 3 years or if it can wait for another year or what have you. So there are guidelines for that. Smear should not be performed before 21 years old. At 30 years old, pap smears can now be performed every 5 years, right? So a pap smear with HPV co-testing should be performed. If those are completely negative, then every 5 years after that. But that does not mean you had a normal at 30. You should don't have to go back to the doctor for 5 years because this is just a pap smear is just looking at the cells on your cervix. That's it. To see if there's cervical dysplasia, if there's issues on your cervix. You have a uterus, you have fallopian tubes, you have ovaries, you have breasts, you have a multitude of different other things in your body that need to be addressed other than just your cervix. So that's one as far as the pap smear is concerned and looking at your cervix. You should also be getting breast exams and mammograms. So for every woman that's younger than 40 years old that does not need a mammogram, you do need a breast exam yearly. And you should also be practicing breast health self-awareness, meaning knowing what your normal breast tissue feels like, knowing that if something is abnormal, or knowing that this lumpiness has a lot to do with just my hormone changes is going to go away. It's not anything to be concerned about versus a hard lump or very painful mass that you should be worried about. Understanding how that feels and how that is a conversation that you should be having with your doctor so that you know early detection is the best and the best prognosis as it pertains to treating and getting through any type of breast cancer. But a breast exam should be performed once a year and frequently from a self perspective, but they should be starting mammograms at the age of 40 unless there's a strong family history of breast cancer and ovarian cancer in a family that may change that 40-year-old mark. Colonoscopies should be for African Americans should start at the age of 45 unless there is a strong family history of colon cancer or cancers in the family. Myself personally, my father had colon cancer. All transparency, I got my first colonoscopy at 40 years old. There was a benign polyp found. The recommendation was to come back in 5 years instead of the 10 years. That's my own personal thing. But to that point, everybody's different. Your family issues, family history is different. Your history is different. This is a conversation that you should have. So, but in the nutshell, for African American people, it should be starting at 45. Other cultures, it can be at 50, but those are 50 years old. So those are conversations that should be had. Also, you should be having blood work done, right? So for women, you should be having your blood count, your metabolic panel, your thyroid panel, your lipid panel for your cholesterol, your hemoglobin A1C to check for your blood sugars. All of those things should be done, especially the older that you get. The younger women should don't need all of those things, but getting a blood count, getting a metabolic count will also lead early detection of potential problems, right? How do you know you have a thyroid issue, right? You're getting labs, right? You've gained significant weight. You're having issues with losing weight. You try diets, you try everything. Well, this could be an indication that you have a thyroid issue. This could be an indication that you have some type of other hormonal or metabolic issue, PCOS, other different things that could be going on in your body. But the only way you would know this is if you have this conversation with your doctor is thorough and getting the lab testing that you need. So these are some of the yearly things that you need. And for women, you should be getting pelvic exams, right? So pelvic exams doesn't mean speculum, doesn't mean putting this metal thing or plastic thing in your vagina and just taking a look, because you oftentimes don't need that unless you're getting a pap smear or a vaginal culture. But you should be getting a what's called a bimanual exam, right? Which is basically the doctor filling your uterus, filling your ovaries, right, during that annual exam to see if there's any pain, if there any masses or whatever. That's also early detection. You can detect, early, large fibroids or early fibroids just from a pelvic exam. You can detect ovarian cancers from a pelvic exam. Those things should be done. That's something to just say, oh, I'll just do blood testing or what have you. If you're going to get annual testing done, that should be done because there are things that could be happening in your body that you don't know about. It doesn't mean you have to get ultrasounds every 6 months or what have you. I don't need an ultrasound. I can tell you if you have fibroids just with an exam, right? And to tell you how big those fibroids just with an exam. So those are some of the things that should be done every year for not only maintenance but also early detection of many of the things that we have issues with, in our bodies.
That's very helpful. Thank you so much for that comprehensive overview of screening. And Dr. Pete, thank you so much for being with us this year during Fibroid Awareness Month. We're looking forward to feedback from this conversation and really appreciate all that you bring to our organization.
Thanks for having me. I mean, you all are doing phenomenal work. I am, just blessed to be, in collaboration with you. I'm glad we met, and I'm glad we are able to help women. It's ironic. My birthday is July 1st, which starts off
Oh,
Fibroid month. So
isn't that
it's
something? Happy
it's kind of
belated
crazy. I
birthday.
appreciate it. Thank you very much.
Okay.
So yeah, this is awesome. I'm happy to do this.
Thank you again.
All right.